All right. Well, good afternoon, everybody. Happy second day of AEP. For those of you who I don't know, my name's Courtney. I am with National Contracting Center. We also have Brandon Hall with National Contracting Center and our very own Jackson Johnson as well. So we're going to be very respectful of your time, considering it is day two of AEP. And we are going to jump right in to our Wisdom Wednesday on this 16th day of October. And we're going to start with what we learned day one of AEP. So yesterday was kind of a figure it out day, not just for us and you guys as agents, but for Medicare.gov. They had to figure it out. They had a small little glitch in their system for a few hours, and the Medicaid verification system did as well. So please just kind of be patient with those type of things. Have your backup plans, whether it is from being able to use Sunfire to having to pivot and use a carrier specific e-app platform. Make sure you do have your options. Lots of carriers are starting to require paper apps. Anthem being our main, I hate to say offender, but I just don't have a better word for that at current. So all their PPOs are to be paper app and faxed in. They will accept e-faxes, so that makes things a little bit better. They will also accept DocuSign or Adobe Sign. So you can, in all technicality, still email those and proceed as though you are doing a normal-ish e-app. So that does take a little bit of the weight off. A special reminder that with Aetna on their PPO plans, you do have to choose a primary care physician. If you do not choose a primary care physician on the Aetna PPOs, one will be randomly chosen for the client. That leads typically to a ton of confusion. So please make sure that you're asking your client who their PPO or PCP is, adding that to the PPO app so that when they get their cards, the right information shows on there and kind of avoids some of that confusion from a client aspect. Again, the e-apps did have some glitches as well. Sunfire, we have noticed, is very accurate on drug pricing. Other platforms are not, including Medicare.gov. So please, if something doesn't look right, please take note of that and make sure that you're double checking. Jackson is going to explain a lot more about some of the drug prices that you are seeing and why certain things may not look quite right, but they actually are. So he's going to take care of that here in just a few minutes. But overall, for day one, it was insanely busy and productive across the board. So kudos to all of you for working so hard in the lead up to AEP to be so productive. We had lots of agents in the double digits with their app submission count on day one, which is fantastic news. Please keep up the hard work. We have tons of areas that had lots of disruption. So the business retention part is taking up a lot of time. If you're in one of those areas, please make sure that you're using that time wisely and asking for referrals at the end of each one of those appointments so that you are able to generate new business along with your retention. And don't forget to cross-sell. A lot of agents are rushing around. Your best lead is who you're sitting or talking to at that time. So please don't take that for granted. Use your ability and your sales skills to position some ancillary products, whether it be a hospital indemnity or a dental plan. Use your time wisely. Make sure that your clients feel like they are the absolute center of your attention and that you're there to do the very best for them. And cross-selling will actually help you do that because you're giving them the option as to whether or not they want to buy something. You're not being overly pushy, but you're also giving them some choices and letting them know how that they can cover their costs in a manner that might be a little bit easier for them to handle. So outside of that, I will open it up just for a brief second before I turn it over to Jackson and see if anybody has anything to add as to things they learned on day one of AEP. And then Jackson will get started with our PDP information. You can come off mute. It is a session in which we would love to have any participation. So you can type in your chat or just unmute yourself and go from there. Well, Jackson, I want to turn it over to you, sir. You can go ahead and go through MOOP and Troop and all the interesting PDP pricing out there.
Okay. So everybody, what you may have seen so far is some significant changes versus 2024 in terms of estimated out-of-pocket drug costs. So for a couple of years now, we've been hearing about this Inflation Reduction Act and how it's instituted a $2,000 drug MOOP. And many of us, myself included, initially thought that was a $2,000. Once you pay $2,000 out of pocket, you don't pay anymore. Well, just like everything in our business, it's not quite that simple. So the $2,000 drug MOOP calculation is actually based on true out-of-pocket costs, or TROOP. And so we'll look at a couple of examples here in a minute, but basically, here's what the $2,000 boils down to. Your clients, the greater of what they actually pay for a drug on their plan, or what they would pay on the Part D defined standard benefit, the greater of those two is what goes toward their $2,000 MOOP. So the defined standard benefit is a minimum standard that CMS sets that every drug plan, whether it's a standalone Part D drug plan or attached to a Medicare Advantage plan, it has to at least meet this minimum standard. And so the defined standard is a $590 deductible, and then 25% of the retail drug costs until that beneficiary has paid $2,000. So your very, very, very inexpensive drug plans, like for example, a WellCare value script, is going to be closer to that than most Medicare Advantage drug coverage. And so we'll show an example here in a second of what that actually looks like, and then break down what that means for your clients. But if you have seen drug costs quoted at $400 estimated, or if somebody's on really high price drugs and you're seeing estimates come in the $1,400, $1,500, $1,600 range, just know that that is accurate. From what we've seen so far, it will be nearly impossible for somebody to pay a true $2,000 max out of pocket. On average, what we're seeing so far is like $1,600, $1,700. But I want to show you a potentially extreme example. So I'm going to pull up my Enrollment Central here. Okay, so here's what this example is showing. So I have 4 very common low price tier 1 medications in here: atorvastatin, escitalopram, levothyroxine, and metformin. So on almost any plan you're going to find, these are going to be tier 1 $0 copay drugs. So for example, here in East Tennessee, the Blue Cross Blue Shield Sapphire plan, if someone's on those 4 drugs, their estimated drug costs out of pocket are going to be $0. And even if we go over here and we look at Part D plans, the WellCare value script is going to be their cheapest one. They're going to pay $60 We can go in here and look at what those actual costs break down to, but it's going to be very inexpensive. So the escitalopram is going to be a tier 2 drug, so a $5 copay, $60 for the year if somebody's on these 4 drugs. So with tier 1 and 2 generics, it's not that big of a deal. Where we're seeing huge discrepancies between drug plans and advantage plans, though, is when somebody is on a tier 3 brand name. And so let's look at an example here. Let's add Eliquis. And there's one more example we're going to look at as well, but let's just say somebody's on 2.5 milligrams of Eliquis twice a day. Now, when we requote this and we look at the estimated drug costs, you'll see some big discrepancies here. So on the Blue Cross Sapphire plan, their estimated drug costs are only $462. It's pretty similar here on the Humana Gold Plus 041 plan. If we go into the details, levothyroxine, metformin, escitalopram, atorvastatin, they're all tier 1s. Eliquis is tier 3. The retail cost of this is $550, but it's a tier 3 with a $42 copay. Now, if somebody's on this plan, they're going to reach catastrophic coverage in November, and they won't pay anything for the drug in December because they've, by CMS's standards, reached their $2,000 max out of pocket. Well, how could that be when their estimated drug costs are only $462? Well, again, the defined standard benefit for this drug or period would have them pay a $590 deductible and then 25% of this cost above that deductible, or roughly $130, $140 per month. So what's counting toward their $2,000 MOOP is the greater of what they actually pay, this $42, or what they would pay, which would be about $135. That's why they hit catastrophic here in November, don't pay anything in December, and their true cash out-of-pocket costs next year are estimated at $462. So one more example I want to look at, and then we'll really break down the differences here between PDPs and MA plans. But let's take Eliquis out and let's add Ozempic. So Ozempic on most MA plans that we've seen so far. By the way, any of these dosages are all treated the same with most carriers. Ozempic is a tier 3 drug on most Med Advantage plans that we've seen. And so again, that's going to be around a $42 copay. Now, what makes Ozempic unique is how expensive it is retail. So if we look at this same plan, Blue Cross Sapphire, again, levothyroxine, metformin, escitalopram, atorvastatin, they're all tier 1 generics, $0 copay. Well, the estimated full drug cost of Ozempic is $912 per month. On the defined standard benefit, the first $590 in drug costs that someone incurs in 2025 will go toward their deductible, and then they'll pay 25% over that. On this Blue Cross plan, there is no deductible, and tier 3 drugs have a $42 copay. So on a monthly basis, let's take January, for example. The first $590 of this 912 is going toward their 2000 MOOP, plus 25% of the difference between 912 and 590, whatever's left over. Whereas they're actually only out of pocket $42 in cash. Now in February, they've met their deductible. Now they're paying a full 25% on the defined standard benefit out of this 912. And that's good. So roughly $250 or so dollars. And we'll look at this broken down further here in a second. But in this particular instance, somebody would hit catastrophic coverage in July. and they would not pay anything for their drugs the rest of the year. So here's what that looks like if we compare it side by side. So if we say Ozempic is $1,000 retail for sake of this example, or it could be any drug that's $1,000. If it's a tier 3 and on a Medicare Advantage plan with no drug deductible, they have a $42 copay. This is what they actually pay every month, this column. The month that's counted toward their the amount that's counted toward their $2,000 MOOP is actually $590. The first $590 out of this 1,000 plus 25% of everything over that. So roughly another $100 in January. So suddenly by the end of the month, they're $690 toward their max out of pocket when they've only paid $42. And as you can see, every month after that, it's $1,000 retail. They pay a $42 copay, but the defined standard benefit is 25% or $250. The greater of these two is counting toward their MOOP. So the MOOP, the amount contributed toward the MOOP goes up from $690 to $940. And so you can see in this very simple example, they crossed the $2,000 mark in July, and that's why they don't pay anything in August or on. Now, I want to compare again in Sunfire here some cost breakdown between an average Medicare Advantage plan. And of course, these Medicare Advantage plans depend on the service area. But here in East Tennessee, for example, this Blue Cross Sapphire plan is going to be one of the leading plans that we sell during AEP. Somebody on these 4 tier 1s and this tier 3 Ozempic is estimated to pay $294 total out of pocket next year. Now, if we go over here and we look at Part D plans and we sort by estimated drug cost, the cheapest they would come out of pocket is $315, which is close to what they would pay on the Sapphire plan. But this Humana Premier Drug Plan comes with a $120 monthly premium. And if we look for something that's a little lower cost, like this Cigna Saver plan, for example, that's only $27, they're going to pay $1,500 out of pocket for their drugs versus the $294 they would with Blue Cross. So basically, the reason for that is Medicare Advantage plans are being reimbursed from CMS for both health and drug expenditures. So there's a bigger bucket of money to spread this cost out over. Drug plans, it's all prescription based. So if what we're seeing, just to boil it all down, is almost every single person on a tier 3 brand name drug is going to be better off on a Medicare Advantage plan next year than a PDP. Because what we're not factoring in this example is roughly $100 to $150 Medicare supplement premium that somebody's also paying if they're on this Humana Premier plan. So the Humana Premier is $120. Let's say they're paying another $120 for a Medicare supplement. That's $3,000 a year in premiums versus this Blue Cross plan that's $0 premium for the same drug cost. So we can save them $3,000 in premium, replace it with a Medicare Advantage plan that has a $0 primary care copay, a $30 specialist copay, $2,750 in dental cost, 170, I think it's 100 and no, I take that back. It's about $255 a day for inpatient hospital stay for the first 5 days, but we could sell them a hospital indemnity plan for roughly $30 a month. That would cover that. This plan has a $4,200 max out of pocket on the health side, but basically the only way they're going to hit that is if they have multiple inpatient hospital stays, or they have to take Part B drugs like chemotherapy. And so this is where we would recommend you as an agent in a situation like this, sell them a $0 plan with a hospital indemnity plan with a cancer rider. All in, it'd be about $50 a month versus the $240 they would be paying on a supplement plus drug plan. So you're saving this person $200 a month, and there's almost no chance they hit their max out of pocket. Now, if we just go back to this example and we say, let's take Ozempic off. Ozempic is going to be one of the higher priced tier 3 drugs that you're going to run across. But if we use Eliquis again, very common medication, common dosage, and take the same example. Their estimated out-of-pocket drug costs on Blue Cross Sapphire are $462. If we find a comparable drug plan, so if we sort this by lowest estimated drug costs, again, the Humana Premier plan comes up cheapest. If we sort by estimated total cost, even this Cigna plan, their estimated total costs are $1,800. Versus 462. That's a $1,400 difference. And now you're selling a Med Sup and PDP versus a Medicare Advantage plan, because the Advantage plan is going to save hundreds, if not thousands of dollars. So again, what we're seeing, if somebody's just on a bunch of tier 1 generics, it's probably not as significant of a difference. But especially if they're on tier 3 drugs, they're probably better off on a Medicare Advantage plan next year. So again, the reason you're seeing this number as low as 462 is because the $2,000 drug MOOP is not simply what they're paying out of pocket. It's a much more complex calculation. So our recommendation is that you as agents have a working knowledge of this, but a simple explanation to clients is there's new regulation and new plans available that have significantly lowered the drug costs for everybody, but in particular Medicare Advantage beneficiaries. You probably won't need to go into any more detail than that, but keep in mind, if you're using Sunfire here or Enrollment Central, you can go into the plan details, go to drug cost details. You can look at each medication individually here, and then you can go and look at a monthly estimated cost breakdown. And you can show this person that by July, they will reach, or in this case, I moved this to Eliquis actually. So November, they'll reach catastrophic. December, they will not pay anything for their drugs. Their estimated drug cost for the whole year, $462.
Jackson, can we
Go ahead.
clarify a little bit how the deductible of these plans, if it's included, is already worked in to their out-of-pocket cost?
Yep. So let's just take this Eliquis, for example. So on this Blue Cross plan, there is a $0 drug deductible. They're going to pay in January $42, a tier 3 copay. The CMS defined standard benefit has a $590 deductible, meaning the first $590 worth of these drug costs is actually counting toward their 2000 MOOP, even though they're not paying it on this plan. And then if we look at February, for example, according to the defined standard, they would have already met their deductible. So they would pay 25% of this 559, which would again roughly be $140 or so. But their plan benefits are only $42. So the greater of those two, the 140 is actually counting toward their MOOP. So that's why they're hitting the 2000 MOOP much quicker than they're actually spending 2000 out of pocket. And we're seeing this across the board, all states. There are many plans that do have a $590 deductible on tiers 3 through 5. Almost every drug plan does that's under $100. But there are plenty of Medicare Advantage plans that do not have that drug deductible, which means they're automatically saving $500 to $600. So if you've seen some prices like this that shock you, just please know this 462 is accurate. And I will caution you, one of the reasons we wanted to educate agents on this is because we have had to reach out to multiple carriers because the carrier sites have quoted this incorrectly. And we have actually had to reach out to their pharmacy teams, and their pharmacy teams have had to go read the CMS documents and change the way the software quotes. So we felt it's important that you as agents have at least a working knowledge of this. So when you see prices come in at roughly $1,400, $1,500, $1,600, and they're hitting their max out of pocket, or even $462 and they're hitting their max out of pocket, that is correct. But we felt it was important for you to know this and be aware of the discrepancies too between drug plans and Medicare Advantage plans. So that's as simple as we can make this. There's about 65 pages of CMS documentation about how all this is billed, if you want to read that. But just know we highly recommend you use Enrollment Central here, and these drug prices are quoting accurately.
Please remember, if you have any questions, you're welcome to come off of mute or type them in the chat, whatever is most easy for you. So in a year full of changes, we're trying to get you guys information as quickly as possible through webinars like this, and also through our social media, which I am going to turn over to Brandon, so he can clue you in as to how to follow us to get the most up-to-date information possible.
So guys, Courtney's absolutely right. We want to stay in touch with you guys. We do have our emails, we have our text. If you aren't signed up for our texting, please go to our website. You'll see it down in the bottom right, that nccagent.com. You can sign up for our texting service. And if you ever have questions during AEP, if it's real quick, you can just send us a text. We'll get that to the right department and we'll get you an answer just as soon as possible. That might be even faster sometimes than getting a phone call through, depending upon who is on the phone and how long we're talking. We want to get those questions answered. We also want to get information to you guys. And so these are the socials that we're on. Facebook, you can find us under Medicare Marketing on Facebook. We're on Instagram, is NCC Agent. We're on YouTube at NCC Agent. We put content on those three repeatedly throughout the weeks. If you're on LinkedIn, just search National Contracting Center. We are there. And if you are on Twitter, at NCC Agent, we use that more for just getting out quick hit information because the character limit is smaller on there. But Facebook, YouTube, LinkedIn, we try to put more detailed content. And then Instagram, you can kind of follow us as we put out different social interactions that we have. But we're here for you guys. Any way that you can interact with us, we'd love to. We still have our emails up. We still have our phones. We answer those, and we're going into probably the busiest AEP that we'll have in a while. And we want to be here to help you guys any way that we can. So through any of our channels, just reach out. I know anybody here will be glad to talk to you and answer any questions you have, work through any issues that you have. Heck, today's the second day, and we've all been covered up helping agents, and it's what we like to do. So hit us up on any of these socials if you're on there. If you're not on any of these, I would ask you to sign up and start for part of your branding of your agency, of your business. Courtney's a big proponent of branding yourself. Part of that is to have an online presence, and we can walk you through that. We have a Facebook toolkit. We have an online presence guide. Reach out to us in the marketing department. We'll be glad to sit down and have conversations with you about that. Maybe not during AEP, but we can have those conversations.
Thank you, Brandon. I did forget to give you guys a little bit of good news. We found out yesterday, so sorry about that. But Aetna is going to pay on their DSNP HRAs. Those are available through Think Agent currently, and will pay at $55 per HRA on the DSNPs. So that is fantastic news for Aetna. A little kind of last minute bonus there if you're writing their DSNP plans. But information like that is what you're going to find in our posts and everything else that we're doing on social media, our website, our emails. So please make sure that you are staying tuned on each one of those. I don't even know what to call them. I'm horrible at social media. I'm a huge proponent of it, but I don't know how to use it. So there's that. That's what we have Brandon in our marketing department for. Those guys are fantastic. So please reach out. Let us know what we can do to help you. It is AEP, so I'm going to give you guys back your day. We appreciate you joining us. And like Brandon said, if you have any questions, we are all happy to help, and we appreciate everything you do. So we will talk to you soon. Have a fantastic day.